This is not a cough. I was clearing my throat. Hi everyone, it's Dr. Zeina. I hope you're well. Now, I talked in my last video about how quiet the surgical on-call has been, and since then it seems like it's not just the surgical on-call, but the entire surgery department has been much less busy recently. Now, I talked about the reasons why in the last video, but just to recap, we've cancelled all elective and non-urgent operations to make room for coronavirus patients, and it seems like fewer people are coming into hospital, maybe because they're scared of contracting the virus. As a result, the surgical department has been much less busy over the last 2 to 3 weeks or so. But during the same time, there are other parts of the hospital that have gotten much more busy, and these include a lot of the medical wards and the ITUs especially. So we hear a lot on the news about how stretched the ITUs are, how few ITU beds we have, and actually, even though my hospital is creating new ITU beds, the staff there are still under increasing pressure every day. So a decision was made between the surgical department and the ITU department that any doctors who have more free time these days because of fewer surgical patients would be called to help out on ITU. So the ITU environment is a much higher risk for contracting the disease if you're a staff member. Firstly, that's because the patients there are more unwell, so they're more likely to have a higher load of the virus. And it's also because of the procedures that they undergo in ITU. For example, when you're putting someone on a ventilator, a machine that will breathe for them, you first have to intubate them, which is when you put the breathing tube down their throat. Now, this procedure is classed as aerosol generating. So because this virus travels in heavy droplets, we think that most infections happen from touching surfaces. So people touch a surface, then they accidentally touch their face, and then it gets into their body that way. But in ITU, the risk is higher. When you do something like ventilation, for example, when you're intubating someone for ventilation, that's classed as aerosol generating. And what that means is that it produces a large volume of air, and this air might carry the virus, and so it's possible to get infected by breathing it in, not just by touch. And that's why you have to take much greater precautions. So beforehand, when I was on a normal COVID ward, the guidance was to wear a normal surgical mask, an apron and gloves, and that was considered sufficient to control the risk in those environments. But on ITU, you need a much higher level of protection. So for example, this includes wearing 2 layers of gloves, a surgical gown, a higher standard of mask, visor, and a hat to cover your head, a surgical kind of hat. And once you put that on, they call that your skin. So you can wear more things on top of that. So let's say you're going to do a procedure which would usually require 1 pair of surgical gloves. You'd keep on these 2 pairs of gloves, this surgical gown and everything else. You can wash your hands in these surgical gloves. It feels really weird. You put gel on these hands, alcohol gel, and you wash the gloves. And then you put on another pair of gloves, so a 3rd pair of gloves, and then you do the procedure. And these precautions are all to stop potential virus particles from contaminating you. Instead of getting on your skin or your scrubs underneath, they get on this gown which you can take off afterwards. And because of the high risk involved, there's a very specific process for getting these things back off. And they say that there's a higher risk of contamination actually when you're taking these things off than there is when you're putting them on. So that's something we have to pay a lot of close attention to. So there's lots of talk in the UK, in America, and all over the world about this PPE shortage. And I've found limitations in some things at my hospital, but I don't think this leads to us being unsafe. At the moment, it just limits the specific kinds of equipment that we can use. So for example, the World Health Organization recommends wearing gloves that go from your hand all the way up to your elbow. We do have these gloves, but only in a medium size. So you can choose, do you want to wear these longer gloves in a slightly wrong size, or you can wear normal surgical gloves, which still offer decent protection. They go up to about there, so you can wear those in your size. Specifically, we've heard about this shortage of FFP3 face masks, and I know lots of hospitals nationwide and internationally are low on these masks. But again, I don't think that affects our safety day to day, because instead of providing lots of these disposable face masks, they've given each staff member their own reusable respirator mask. So It's a very good quality mask, but it just has to be cleaned in between uses and it has to be stored especially so there's no contamination when you're going between patients with this mask. So it's great having the personal protective equipment that we do have. And actually it makes you feel really safe having that equipment available. So I feel more safe on ITU with all this equipment than I did on another normal COVID ward which didn't have the same level of protection. So that's really good. There's something you don't hear about on the news is that it's very uncomfortable wearing this equipment. So if you imagine you're wearing clothes already, let's say normal scrubs in a hospital, and you have a gown on top, and then you start putting layers on top of that. So you're wearing 2 pairs of gloves, it gets very sweaty and hot in your hands. You're wearing this mask that restricts your breathing, but also that's how you know it's working. You've got this visor on that's dirty, you can't really see clearly through it, this hat, all this other thing. If you're seeing a patient, you put on another apron and more gloves. So wearing these things for hours on end, it's really uncomfortable. And let's say you start seeing patients around 9 o'clock or 9:30. By 12 or 12:30, just 3 hours in this PPE, and people get really, really uncomfortable, and everyone's just trying to leave. And as doctors, we're really lucky because we can see all the patients and then leave. My sympathy goes out to all the nurses that have to wear the same equipment and stay by the bedside all day for much longer hours. And once I was in there, it was a very different environment to what I was used to before. And there's lots of new things that I'm learning as I go along in this new ITU setting. For example, ventilators. They're this life-saving piece of equipment that we know we're very short on. Tesla and vacuum cleaner manufacturers are all scrambling to make these, but actually they're very intricate, and I'm very slowly starting to come to terms with the settings and what they mean and how to interpret the various numbers on there. There's lots of numbers. There's the PEEP, there's the P-peak, CPAP, I to E ratio, all these things. There's a whole new language, and I'm slowly coming to terms with that. And because of the continuous need for monitoring of these patients, and because of the kinds of medication that they're given, they need special kinds of lines. So whereas a normal patient might have a cannula going into the front of their elbow, and you can have most drugs through a cannula. So most patients have their blood pressure monitored with a cuff. So that's the same kind of blood pressure monitoring that your doctor might do when you see them. They put a cuff around your arm, inflate it, deflate it, and then measure your blood pressure through that. But you can only do that so often. On ITU, they would like to have the blood pressure as often as possible, so beat to beat. Every time the heart beats, you want to know what the blood pressure is. That's done with an arterial line, which is a specialist kind of catheter that's used in ITU settings. And some of the medication that's given on ITU is very irritating, and it can damage small veins, so the kind of veins that you get in your arms. These drugs instead have to be given through a central line, which goes in through the neck and it extends down near to the tip of your heart, where there is a much greater amount of blood flow. So any medication that goes in there very quickly gets into the bloodstream, and it has less of a chance to damage the veins. Now you can also use a special kind of the central line to take blood and give blood at the same time, which some of these patients need if their kidneys aren't functioning properly, and you're giving them dialysis through this line. So there are these 2 special kinds of lines that you see a lot on ITU, but you don't see them very much elsewhere. And these are arterial lines and central venous catheters, or central lines. And there's a special kind of this called a vas cath. And last week I got to see both of these types of lines being put in. So I saw an arterial line being put in, and I saw a central line being put in. And I've also had training on this. So it's going to be a really good opportunity to get to practice these kinds of procedures over the coming weeks. So those were some of the things that I learned during my time in ITU last week. As I said, I'm going to be spending much more time on ITU over the coming weeks. So if you have any questions or anything else you'd like to learn about what happens in ITU, comment down below. If you enjoyed this video, please give it a thumbs up and subscribe to see more like it. I'll see you next time.